Second Cranial Nerve, Neuro-Ophthalmology, Part 2. Neuro-Ophthalmological Examination of the Afferent Visual System. The Neuro-Ophthalmological Examination combines ophthalmic examination techniques with neurologic localization. It is essential for evaluating disorders affecting optic nerve, retina, visual pathway, cortical visual center. Examination of visual acuity. Visual acuity measures the spatial resolution of vision and should always be tested in each eye separately with the patient's best optical correction, that is, with glass, pinhole, or refraction. The result is termed as best corrected visual acuity. Distant and near vision. Distant vision usually tested up to 20 feet or 6 meters. Near vision tested at 14 inches or 0.3 meters. Interpretation is normal is 20 by 20 or 6 by 6 normal visual acuity. For the near vision, we use cards. That is, the near card may contain the numbers or the written text. When these two are tested separately, discrepancies between the two methods can suggest cortical dysfunction such as language disturbance. Coming to pattern and likely cause, better distance vision than near vision suggests presbyopia. Better near vision than distant vision suggests myopia. Contrast vision testing. Contrast sensitivity evaluates the ability to distinguish adjacent area of different luminescence. Reduced contrast sensitivity occurs in cataract, optic neuropathies, retrobulbar lesions. Special charts are used for this. 1. Pelly-Robin chart. The contrast sensitivity is tested using the chart shown. Next is Sloan chart. It is for testing the contrast visual acuity. Light stress test or photo stress test. It is used to detect subtle macular dysfunction. The procedure is measuring the baseline visual acuity, shine bright light into one eye for a period of 10 seconds, asking the patient to read the next largest line immediately after the light, and we should check the recovery time. The recovery time and its interpretation. If it takes few seconds, it is normal. If it takes more than 50 seconds, it is abnormal. If it takes several minutes, suggests a macular disease. Color vision testing. Dyschromatopsia may indicate the lesion in optic nerve disease, retinal disease, cone rod dystrophy. There are some conditions where they have congenital color deficiency, occurs in 8% of men, 0.5% of women. Bedside testing is by red desaturation. That is, patient compares brightness and intensity of a red object between the two eyes. Reduced saturation suggests optic neuropathy. We have the formal test. Those are Ishihara plates, Hardy-Rand-Rittler plates, Farnsworth-Munsell test. Examination of the pupils. In pupils, we should look for size, shape, direct light reflex, consensual light reflex, near response, RAPD, that is relative afferent pupillary defect, and anisocoria. If there is unequal pupils, then we should look for associated ptosis and assess for the ocular motility also. Light near dissociation. It is an abnormal condition where near response is stronger than the light response. This is seen in Adie's tonic pupil, dorsal midbrain syndromes, severe bilateral optic neuropathy. Relative afferent pupillary defect, also called Marcus gun pupil. Detected using swinging flashlight test. The principle is normal. There is direct and consensual response are equal. With optic nerve dysfunction, the affected pupil paradoxically dilates when illuminated. This is called RAPD. Important points are, it indicates unilateral or asymmetrical optic neuropathy. It is not present when there is symmetrical bilateral disease. Severe retinal disease can also produce RAPD despite optic nerve being normal. Light brightness comparison. It's a subjective version of RAPD testing where patient compares brightness between two eyes when a bright light is alternately shown into each eye separately. It is useful for optic neuropathy, differentiating from the macular diseases. Visual field testing. It is essential in evaluating vision loss. The methods are confrontation testing, Amsler grid, perimetry. Confrontation visual field testing. It's a basic method where patient cover one eye, fixates on examiner nose, examiner tests all the quadrants. Technique is by finger counting, simultaneous lateral stimulation, and hand comparison. Clinical utility is it helps in detecting hemianopia, quadrantanopia, visual neglect, constricted fields. Redox phenomena. Patient here perceives the moving targets but not the stationary targets. It occurs in visual cortex lesions, causing homonymous hemianopia. Hence, finger counting may be the superior method to the wiggling of fingers. Functional visual field constriction. When there is organic disease, visual field will expand with increasing examiner's distance from the patient. That is, they will have a funnel pattern of visual field constriction. When there is functional loss, the field will remain the same size, that is, in the form of tunnel type of visual field constriction. This is how we differentiate organic versus functional visual field constriction. Amsler grid testing. It evaluates the central 20-degree of vision. The questions asked are, can you see the center? Are corners missing? Are lines distorted? Depending on the answers, we can assess the defect and interpret it. If there is a missing center, central scotoma should be suspected. If there is half missing, hemianopia. If there are wavy lines, macular disease, that is metamorphopsia. Chiasmal lesions. True bitemporal hemianopia strongly suggests the lesion in the optic chiasma. First image here shows normal binocular vision. Second image shows bitemporal hemianopia. Visual field defect association with the visual pathways. In the first chart, we can see the first one decreased vision in right eye, suggesting right optic nerve lesion. Second image, junctional scotoma, lesion in posterior right optic nerve. Bitemporal hemianopia, lesion at optic chiasma. Right homonymous hemianopia, lesion in the left optic tract. Right homonymous sectoral anopia, left lateral geniculate nucleus. Right homonymous superior hemianopic defect, left temporal lobe. Right homonymous inferior hemianopic defect, left parietal lobe. Right homonymous inferior quadrant anopia, left occipital lobe. Right homonymous superior quadrant anopia, left occipital lobe. Right homonymous macular sparing hemianopia, left occipital lobe. Right homonymous scotoma, tip of the left occipital lobe. Second image, first lesion, left optic nerve. Second lesion, optic chiasma, bitemporal hemianopsia. Third lesion, right optic tract, incongruous left homonymous hemianopia. Fourth lesion, left lateral geniculate nucleus. Right congruous homonymous sector anopia. Retrochiasmal lesions. 1. Incongruent hemianopia suggesting anterior retrochiasmal lesion, that is optic tract and temporal lobe. If there is congruent hemianopia, that is, it usually indicates occipital lobar lesion. Incongruent homonymous hemianopia. Here, a visual field defect affecting the same half of the visual space in both the eyes, but the shape, size, severity of the blind spot is highly asymmetrical between the left and right. It localizes to the lesion in the anterior retrochiasmal location, that is, closer to the optic chiasma. The specific structure is optic tract. The lesion here characteristically present with highly incongruent defects, often accompanied by RAPD. Temporal lobe specifically damage to the lower fibers, that is Meyer's loop fiber, results in an asymmetrical superior quadrant defect, classically nicknamed pie in the sky defect. Why it happens? In the anterior tracts, the nerve fiber originating from corresponding point of the two retina are still topologically separated and have not yet fully paired up. A partial lesion is highly likely to damage the fiber from each eye unevenly, hence incongruency. Congruent homonymous hemianopia. Here, a visual field defect that is an identical mirror image in both the eyes. The shape and depth of the loss of vision matches perfectly. The localization is a posterior retrochiasmal lesion, that is further back in the brain. Specific structure is occipital lobe, typically caused by posterior cerebral artery stroke, tumor or trauma. These lesions frequently present with macular sparing because the tip of the occipital cortex features a dual blood supply. Why it happens? As the visual pathway travels deeper towards the back of brain, the fibers carrying information from identical point of both the retina tightly squeeze together. Any injury to this posterior area strikes both set of fibers completely equally, creating a perfectly symmetrical blind spot. Ocular fundus examination. It is mandatory in patient with vision loss. Direct ophthalmoscopy steps. Dim room lights. Patient fixes on distant target. Examine the right eye with the right eye only. Look for red reflex. Focus on the retina. Follow the vessels to reach the optic disc. Examine for disc edema, pallor, cupping, assessment of the retinal vessels. Also examine macula. Poor visualization may be due to small pupil that may require pharmacological dilatation. Key clinical pearls. RAPD is one of the most important signs of unilateral optic neuropathy. Macular disease prolongs photostress recovery. Bitemporal hemianopia strongly localizes to optic chiasm. Congruent homonymous hemianopia usually indicates occipital lobe pathology. Fundus examination is essential in all patients with vision symptoms.